much time as she needs. So thanks for joining us. And of course, this is our Data Stories webinar series, which covers many topics related to oral health data and has been developed as a learning opportunity for open organizations and members to find and successfully use data to inform efforts in advancing oral health equity. So we found among us that we have a lot of expertise, content experts in our open network or in open. And in response to that, we created these data stories to share innovations and solutions that are happening around the country that can help us to realize our collective vision more effectively and efficiently. So today we are proud to have Jenny Lansing. She's got too many initials behind her name, but among them is MPH, MBA, and registered dental hygienist, and she's the oral health preventionist for the Colorado Department of Public Health and Environment. She's got a nice bio. It's posted on our open platform, and you can see that if you like. So the title of today's presentation is Using Social Determinants to Prioritize Counties with Highest Need. So thank you guys for joining us, and feel free to think about your questions that you might have for Jenny. You can either put them in the chat as we stated, or just save them since there's not that many of us on. So go ahead, Jenny, the floor is yours.
All right, thank you. Let me see if I can get this going. And one more second here. Okay, perfect. Initials after my name, but not anything related to being tech savvy. So sorry for the delay, folks. Give it one more second here. All right. Well, thank you all for taking some time out of your day to spend it with me. As was mentioned, I work at the Colorado Department of Public Health and Environment. I am our oral health preventionist, and today I'd like to talk a little bit about a project that we've been working on our team. Before I dive in, I just want to thank the Open team for organizing this data measurement webinar series, Leveraging Data to Advance Oral Health Equity. And I'd also like to thank the Health Resources and Services Administration and the CDC for providing funding support for the development and implementation of this project. So I'd like to talk a bit about what our team has completed with a chronic disease epidemiologist on staff to utilize social determinants data and prioritize high needs counties in Colorado, and how we've utilized the developed methodology to guide current and future work. And while my background is in oral health and not epidemiology, I hope to be able to answer any questions that you may have. And I welcome future opportunities to connect and discuss these topics further. The Oral Health Unit at the Colorado Department of Public Health and Environment was in need of a methodology to help prioritize oral health resource allocation in Colorado. Existing methodologies utilized modifiable health factors and did not take into account race and ethnicity. So we conducted a literature review to identify the best way to develop a health index. After a thorough review, the county health rankings model was selected as the method of choice based on its ability to identify the burden and risk of health outcomes using a model based in health equity. County Health Rankings is a collaboration between the Robert Wood Johnson Foundation and the University of Wisconsin Population Health Institute, and it's been released annually since 2010. It reports on the performance of the nation's counties across a range of more than 30 health measures. Over the past decade, their methods have been reviewed and refined and are widely regarded as the best practice for ranking counties. The rankings provided by County Health Rankings are frequently used among public health stakeholders undertaking community health assessments, goal setting for community health improvement, and communicating health priorities to the public. The main goal of this project was to improve oral health outcomes and access to care for all Coloradans. the developed methodology and county rankings have been used to identify priority areas in which the oral health unit would increase oral health interventions and also focus approaches to increasing access to care. Our project planning efforts began in the late fall of 2019 and early spring of 2020. Literature reviews were completed in the spring and summer of 2020, and a preliminary methodology was developed in fall. The developed methodology was finalized in late fall of 2020, with a second iteration developed for older adult, Hispanic, Latinx populations in early 2021. Also in 2021, the Oral Health Unit and key partners developed and implemented older adult pilot projects in high needs areas that had been identified by the methodology. The county health rankings model is deeply rooted in health equity, using a model of population health that emphasizes the many social, economic, physical, clinical, and other health factors that influence our health. County health rankings methods are based on a conceptual model of population health that includes both health outcomes and health factors. Health outcomes reflect the current state of health in a county and are split broadly into two components: length of life and quality of life. And this figure helps show how the county health rankings model works. So it shows that everything starts with policies and programs which influence health factors that ultimately determine health outcomes. Since the purpose of the model was to identify oral health needs in counties, we chose to focus on health factors. The health factors are a great predictor of the future health of a community and are thought to be modifiable over time. And as illustrated in the model, a wide range of health factors influence our health. The health factors model is broken into 4 components in the middle here: health behaviors, clinical care, social and economic factors, and physical environment. As a part of the county health rankings model, each component is weighted, and collectively, these 4 components will add up to 100%. One of the most important factors when considering building a health index is that the indicators must be both modifiable and measurable. So for this reason, biological factors such as race and ethnicity are not included in the model. And digging deeper, within each of these components, there are subcomponents. They will collectively add up to the health factor weight. So for example, all of the metrics within clinical care would need to equate to 20% for that health factor bucket or that component. The subcomponent focus areas and the measures that are related to these focus areas had been identified by the oral health unit and the chronic disease epidemiologist. Weights for each measure were also determined by the team, and then they were guided by several considerations, including findings from the literature reviews, input from program staff and subject matter experts, program funding, and weighted measures from other rankings. So our process was truly iterative. We had multiple meetings to go over measures, identify gaps, and then readjust. So each health factor component, like health behaviors, for example, on the screen, has one or more subcomponents. So tobacco use, diet, and exercise. They're defined by one or more measures from various data sources. The rankings are calculated using county level measures from a variety of national and state data sources, like the Behavioral Risk Factors Surveillance System. We utilize Colorado Department of Education data sources, American Community Survey. The data sources that were selected were based on availability, reliability, and costs. And in the next few slides, I just like to take a closer look at the subcomponents that we used within each of these health factors, and the ones that were specifically selected for our older adult pilot project. Similar to the county health rankings model, we selected measures related to tobacco use, diet and exercise, and alcohol use. Examples of the specific measures incorporated into our developed methodology include the percentage of adults who are current smokers, percentage of adult population reporting a BMI greater or equal to 30, the percent of the population who lack adequate access to food, and percent of the population in poverty who do not live near a market. We also included the percent of adults that were reporting binge or heavy drinking. And then there was another measure included related to stress, which was the average number of mentally unhealthy days reported in the past 30 days. We also added a chronic disease measure related to oral health outcomes, such as cardiovascular disease or diabetes diagnosis, and adults who have lost any teeth. For the clinical care health factor, we aligned with the county health rankings model and included both access to care and quality of care. Specific measures addressed the insurance status of adults, as well as the ratio of population to primary care physicians and dentists. The preventable hospital stays measure also aligned with the county health rankings model, and we elected to include the percentage of adult population who had been to the dentist within the past year as another measure. And as you can see in this diagram, the social and economic factors include a plethora of measures. We incorporated measures addressing graduation status, post-secondary education, unemployment status, poverty and income inequality, as well as crime and deaths related to injury. And these indicators and corresponding measures overlap with those used in the county health rankings model. We also included free and reduced lunch and child care services indicators. And the final health factor component, physical environment, included measures and indicators related to water quality and housing, such as the presence of health-related drinking water violations and severe housing problems like overcrowding, high housing costs, lack of kitchen facilities, or lack of plumbing facilities. And then we also incorporated the ratio of fluoridated water per population in this section. Once the data had been pulled from the corresponding sources, the indicators were cleaned and calculated. For ease of analysis, the measures that overlapped with the county health rankings model were pulled from their website and the pre-analyzed data was used. For all other indicators, Z-scores were calculated in order to standardize all measures being used. Since the measures are based on different scales, such as percentages, rates, and averages, each measure was standardized using a Z-score. A positive Z-score indicates the county has a higher value or poorer health than other counties in Colorado. And a negative Z-score denotes the county has a lower value or better health than other counties. For the majority of measures, a higher Z-score represented poorer health. So, think percentage of adults who have lost any teeth. But for measures where the higher Z-score actually represented better health, like the percent of the population who has seen the dentist in the past year, the value was multiplied by -1 and the inverse value was used. After calculating Z-scores for all indicators, measures were multiplied by the assigned weight, and then all measures for each county were summed in order to obtain a composite score for each bucket. The composite scores were then sorted from lowest to highest to rank the counties in Colorado. So the lowest score indicates the best health and gets a composite ranking of 1, whereas the highest score indicates the worst health and gets ranked 64, since there are 64 counties in Colorado. This figure shows the top counties in the oral health unit that the oral health unit identified to work with through this health index. Since the process is iterative, the results will be modified as the methods and the data sources are improved. Next, you'll notice the race and ethnicity breakdown on the right. We did not include measures of age or race and ethnicity in our calculation of ranks because the focus of rankings is on modifiable determinants of health. To incorporate a health equity lens, demographic data was pulled from the census to compare the racial ethnic breakdown of each county with the rankings, and to ensure that our reach also focused on more diverse communities in need. The county health rankings model can be applied to program-specific planning to identify how needs vary across the state. And this work has helped guide the oral health unit in our strategic planning process, as well as to help strengthen partnerships and identify new ways to collaborate. In order to include the race and ethnicity lens, we compared the race and ethnic breakdown of each county with the composite scores. And what we found was the counties with the highest percentages of Black, mixed race, and Latinx populations wound up in our top 10. The counties with the highest burden of healthcare needs and higher populations of Hispanic and Latinx were compared to the current coverage areas of our oral health unit grantees and partners to identify and prioritize communities in need and opportunities for funding support for oral health interventions. The rationale for this is due to the priority populations identified in the oral health unit CDC and HRSA federal grants, as well as based on past and projected demographic growth. Of the top 10 prioritized communities with high Hispanic Latinx population, current oral health unit local public health grantees have conducted or are currently conducting outreach in roughly 50%. There is a public health entity that serves 8 out of the top 20 counties to some degree, which totals about 31–32% of the total population in these 20 counties. The oral health unit has also identified older adults ages 60 and older as a priority population, and results from these analyses show that there was a 100% overlap between our prioritized communities and current oral health unit funded grantees. These results help support the decision to continue funding and to continue prioritizing these areas. In partnership with the Colorado Department of Human Services State Unit on Aging and the Colorado Community Health Network, which is our state's primary care association that supports federally qualified health centers, we provided support to dental safety net clinics for an older adult oral health outreach project. The project was inspired by outreach efforts described in the processes and communications to support priority populations section of our COVID-19 Dental Safety Net Promising Practices report. The Older Adult Oral Health Outreach Project was developed to distribute older adult oral health hygiene and denture kits in areas of high needs through a collaborative effort between dental safety net clinics and local area agency on aging, congregate meal sites, and homebound older adults. Critical human service partners collaborated with a community health center to link older adults to programs to address food, social isolation, and dental needs. Health center staff created videos demonstrating collaborations with their local aging, disability, and resource center. The oral health unit also piloted further expansion of the older adult Hispanic Latinx outreach efforts in dental health professional shortage areas to include outreach through Meals on Wheels as well as a harm reduction association. We also partnered with a grassroots organization, CREA Results, which stands for Community Research Education Plus Awareness, and also means create in Spanish. At the time of our partnership, CREA Results was actually working to increase COVID vaccine rates in the Hispanic, Latino, Latina community. They were also supporting local food banks and health education fairs. The project and key partner collaborations align with several of the open blueprint for structural improvement levers, including amplifying consumer voices, bringing care to the people, emphasizing prevention, and integrating medical and dental. Though, due to the ongoing impact of COVID, addressing and aligning with these levers continues to be a work in progress. The federally qualified health center located in South Central Colorado planned oral health outreach and education at congregate meal sites and through home delivered meal programs. 5 aging and disability resource centers with congregate meal sites are located in this geographic region and located in counties with a designated geographic or low income dental health professional shortage area. Oral hygiene best practices, educational videos were created in both English and Spanish. The health center dental staff provided on-site education, dispensed oral hygiene and denture kit supplies to older adults and meal site staff, and coordinated outreach for homebound persons as well. Due to COVID, the ability to complete on-site dental services was limited and determined by local positivity rates and trends. Meal sites and homebound persons were provided information on clinic locations, available community oral health resources, including information about low-income senior dental grants, And overall, there was positive feedback received from the dental staff as well as the Aging, Disability, and Resource Center. Both organizations indicated a desire to continue these collaborative efforts. Outreach conducted at the harm reduction site also included distribution of oral hygiene and denture kits, as well as information on available oral health resources, information on available dental clinics and providers, and a local dental voucher program, including available transportation services. Oral hygiene and denture kits were also distributed through a local senior resource development agency, though on-site education and service provision were unable to be rendered due to COVID. And in total, CREA results reached more than 1,000 individuals and families and provided oral health education, mini oral health presentations, and distributed oral hygiene and denture kits to persons in need. A few lessons learned along the way include, how iterative the process truly is and truly was. While there's no model that will ever perfectly describe the health of a community, by making the process iterative and continuing to build upon our work, we can hopefully get a little closer and learn a little more about the needs of our counties. And it's easy to assume the more data included will yield better results, but this can actually dilute the results. So we needed to be strategic in selecting measures and assigning weights. Due to the lack of robust oral health databases, as well as a lack of robust sample sizes at the county level, we elected to aggregate more than 3 years of data to have a large enough sample size. In addition to the lack of availability of data sets, we also encountered a lack of population-specific data for communities at greatest risk for poor oral health outcomes. And we do recognize a need for additional surveillance data, which utilizes other data collection methods, such as community-specific surveys and recognition of social determinants of health, leading populations to increased risk. In an attempt to address this challenge for the Older Adult Latinx project, we utilized the Department of Human Services state demographic data set, which included a population estimate classification of minority 60 plus. There were also lessons learned related to integrating different data sets and determining how data sets fit together when they aren't necessarily saying the same thing. We plan to continue to refine measures used as we learn more and discover new measures. A few indicators that have come up recently include an indicator of segregation in neighborhoods and alcohol outlet density. And lastly, the Oral Health Unit is currently utilizing the Priority Communities methodology to guide current projects and plan for future projects. We're continuing our partnership with the State Unit on Aging, as well as increasing collaboration with the Office of Public Health Practice, Planning, and Local Partnerships, and WIC, to bring resources to identified areas of need and to continue to support Colorado's older adult population. The Office of Public Health Practice, Planning, and Local Partnerships, as well as the State Unit on Aging, support the Open Blueprint Lever, amplifying community voices as their trusted messengers working with people and local organizations. The Office of Public Health Practice and Planning and Local Partnerships supports our local public health agencies in completing community needs assessments and developing public health improvement plans. And so one of the strategies that the Oral Health Unit is implementing is identifying the priorities in those public health improvement plans. And regardless of if the priority is oral health, how can oral health support addressing those priorities? So behavioral health and oral health integration efforts, medical and dental continued integration efforts. And we'd like to work towards developing specific indices for different populations. So we're currently planning additional iterations such as school-aged and school-based oral health efforts, as well as the state's Cavity-Free at 3 program enhancements. Ongoing collaboration and partnerships with community-based organizations and local healthcare professionals will also help advance our work. And with that, I'd like to thank you all for your time, and I can open it up for any questions that you might have.
Thank you, Jenny. That was fantastic. Excellent. Thank you. There are a couple of questions in the chat box. And the first one from Is there a short list of survey questions for these social determinants of health that could be used in an outreach intake setting?
Hmm. So that's an excellent question. Can you speak more to that? 'Cause I'd like to hear where your thoughts are going.
Is this Roberta?
Yeah, this is
Yeah.
Sister Roberta.
Okay.
Um, I manage a dental program in Emmitsburg, Maryland. We are not a dental clinic. We help provide access to affordable dental care for people who are uninsured, underinsured, living in poverty. I always start with a pre-service survey with questions with their oral how their dental issues are affecting their overall health, how it's affecting their self-esteem, their their job if they have a job, like attendance and whatnot. Um, I ask like how long it's been since they went to the dentist. But in the very beginning of your presentation, you had about the social determinants of health, of access to medical care, or just healthy water or food, or these other things. So is there a list? I mean, I don't want to spend an hour on a survey for these people, but I'd like to maybe get some other measurable. Does that make sense?
It does. Thank you very much, sister. Let me put in a link to the County Health Rankings website here. I'm happy to follow up with you too, because I want to say we do have a behavioral health specialist on the oral health unit team. And when you talk about assessments and surveys and kind of screening questions for that individual, it makes me think about maybe some resources that we might have that you could compare to what you're asking and see if there's any value in adding to those questions you're already doing. But the county health rankings model on its website, it will show you kind of tobacco use, diet and exercise, access to care, quality of care. It will show you some of these specific kind of buckets. And within there, it will also include a list of different measures that you can pull from. And I don't know if that might help generate some questions or some screening questions to include that address some of those kind of modifiable determinants of health on there.
Well, let's leave it at that for the moment, because I think a future presentation also dealing with seniors would talk about how the variables that they used that came from health variables, but they modified them to fit the oral health needs index, and they're presenting that. I believe it's in May. But anyway, I think there are some groups that are doing that with the basic social determinants of health. But for the sake of time, and we can follow up with Sister Roberta later, um, if that's okay. And then there's one other question from Zeal before I really give it for the last 30 seconds back to Bianca. But was this broken down at all by urban versus rural communities?
Yeah, that's a great question. The oral health unit, the oral health unit and some of the staff at the department have undergone some transitions, and our lead chronic epidemiologist is no longer on the team. I can tell you that we compared rural and urban communities once we had the methodology fully developed and we had the counties ranked. And so our prioritization process included where our known partners were within these metro and rural areas, and who maybe didn't have as many available dental clinics or medical clinics in the area, or places where we might not have been sure which partners were actively reaching those areas. As far as it broken down into urban and rural communities as a part of ranking them, I don't believe so.
Okay. Thank you again, Jenny. We really, really, really appreciate your presentation, and it's thought-provoking. And I think, again, as said, it's going to lead us into some other further discussions that we're planning on, specifically dealing with seniors and dental health needs. So with that being said, Bianca, you'll give us the next webinar, as well as a reminder to answer the survey questions and anything else you need to say. Go ahead.
No, so Sherry got it right. We just need, please fill out the survey. I've dropped it a couple times in the chat. I just recently did. And join us for the next webinar that is occurring on May 11th at 1 p.m. That's Eastern Standard Time. And it's making a difference in the lives of seniors. And that presentation will come from Beth at Senior Charity Care Foundation. Hope to see you all there. I won't take any more of your time. Thank you.
Fantastic. Thank you again.